Good morning. I'm going to discuss a subject which is already well known to you all, but the subject has controversy, multiple information, and the sources are not relevant to the area where you would be practicing. The subject is called obesity. And without wasting much time, I better get on with showing you a slide and then proceeding further to collate information from NICE, American Medical Association, European guidelines, BMJ, Wikipedia, Google, and relevant NHS bodies which have produced information and guidance. So this is obesity with the information at hand in 2025. So let us get on with it and see how best to describe and define obesity. Some years ago, WHO had written out a definition of obesity, which has been revised very recently in 2025. Obesity has been characterized as a medical condition of excessive or abnormal adiposity, which creates risk to health. And the definition includes a description that body metabolic index of 30 plus constitutes the diagnosis of obesity. We are going to discuss as to how BMI, though being a common measure of general obesity, is not truly a method of describing the clinical pathology, the symptoms, and how best to deal with such condition. And further addition to the definition was added when it was realized that weight circumference and its relationship to the height ratio, and in addition, the composition of body as to the proportion of adipose tissue and muscles are concerned, would be more reliable. American Medical Association a few years ago had categorized obesity as a medical illness, which requires treatment as well as prevention. So going on further from it, NICE, about a month ago, through its guidance NG 246, which has replaced the previous NICE guidelines, has emphasized on overweight, obesity, and morbid obesity to be of clinical importance, and that a holistic assessment should be made of the patient, and tactful communication must be maintained before therapeutic treatment is advised. All therapeutic treatment, be they lifestyle intervention, medical treatment through medication, or surgery, will not produce the desired results without appropriate preceding and continuing future lifestyle intervention. Overweight on its own can lead to an increased risk of future type 2 diabetes and becomes a pre-diabetic condition, which also produces early onset of heart disease and contributes to overall mortality increase, in addition to reducing the quality of life. So how does one describe and categorize obesity? The body metabolic index, sometimes called basal metabolic index, must relate to ethnicity and body composition. And this was pointed out by WHO and NICE, and a research publication by Robino. So if someone has a BMI less than 18.5, that person is regarded as underweight and may be nutritionally deficient. The healthy weight range is from 18.5 to 24.9. Overweight would be 25 to 29.9. And this range is reduced with regard to ethnicity. Class 1 obesity would be 30 to 34.9. Class 2 obesity would be 35 to 39.9. So it would be 35 to 39.9. And obesity class 3 would be BMI of 40 or more. With regard to ethnicity, obesity must be accommodated with ethnicity where at a lower body weight but increased waist circumference, cardiac pathology, metabolic disorders such as diabetes, osteoarthritis, and other risk factors develop. Sometimes patients that we see describe their weights in pounds and stones, and most medical calculations with regard to weight classes as well as obesity relate to kilogram and centimeters. So I'm producing below an NHS weight online calculator which converts the pounds and inches or feet to meters and kilogram. So our learning is more understandable to others. This is emphasized by Mr. Terminator. At the age of 20, he scored 30 BMI. But look at the size of his muscles. He has replaced adipose tissues with muscles, which have become hypertrophied, and his risk factors have been reduced because of lower and smaller waistline. He eventually became a governor, a politician, and as I described earlier, Terminator. So why are we interested in identifying obesity and controlling it and preventing it? This relates to a study of prevalence and incidence, and the research was published on BMJ. So in general, this year, 2025, there would be 1 billion children and adults suffering from obesity worldwide. In 2022 to 2023, 29% of adults in the UK were living with obesity. They accepted it. And 64% were either overweight or living with obesity. The obesity rates are highest as 36% in the age band 55 to 64 and 35% in the age band 65 to 74. Among children, 12% aged between 2 to 10 and 19% aged between 11 to 15 suffer from obesity. And it is a rising issue, a growing problem, and we should all be doing our best to prevent it, to control it at the onset if possible, and to follow it up. In general, in the UK, 1 in 4 adults and 1 in 5 children aged between 10 to 11 live with obesity. I've already mentioned that in England, 64% adults live with overweight, and this has risen in the last decade. 1 out of 8 children between 2 to 10 years of age have obesity in England. Looking at the figure work, UK would mean and imply England, Wales, Scotland, and Northern Ireland. The Health Service data collected from England in 2022 suggested that obesity was commoner in the relatively poorer areas of England, such as the North and the Midland. Men suffered by 67%, and women 61%. They were either overweight or obese. Whilst the percentage of women was lesser, as one can see, women had more incidence of morbid obesity. The common age group of both male and female in the adult life band would be 55 to 64. Poverty, reduced or lack of education, ethnicity in relation to immigrants resident in England, and also poor employment result in more obesity. Now, what are supposed to be the causes and risk factors producing obesity? Clearly, if the intake of energy exceeds the burning of calories through expenditure, obviously this imbalance would produce obesity. That means more energy going in, less being burnt out. There are several important factors attached to this imbalance. And the lifestyle factors include food, ultra processed food, fast food, readily available food containing more meat, such as burgers and sandwiches, sugared drinks, fizzy drinks, larger portions of food intake, and eating when not hungry due to social reasons, and accompanied by moderate physical inactivity or a sedentary behavior, taking the lift, walking on travelators, traveling by car, not walking when walking is possible, not climbing stairs, choosing a work style which relates more to sitting and less to walking, not undertaking walking as exercise, bicycle exercises, attending gyms. So, all of these factors are parts of lifestyle matters. Social and psychological factors would mean, I've already described, that poverty, ethnicity, reduced education, overcrowding, difficulty with finding job and promotion would obviously lead to reduced income, whilst the basic expenditure of a family of four, husband, wife, and two children, would remain in the same proportion as it would be if such a person would not be socially deprived. These factors relate to depression, not having enough confidence, accepting the situation blindly, not having medical checkups, and resorting to comfort food. Genetics is also involved. The so called OBS gene produces leptin resistance. What that means is the adipose tissues of the body, wherever they are, have capability of producing or increasing the level of circulating leptin. Leptin produces satiety. That means it leptin increase means a person feels full, not hungry, and would not want to eat further. But there are many factors in genetic conditions which offer leptin resistance. So, therefore, there is constant or frequent hunger when the stomach is not empty, and therefore, this moderate imbalance of increased intake will result in genetic based obesity. We'll be discussing some of the medical conditions associated with obesity, as well as some of the medication in use for a variety of conditions. And for this, I'm grateful to Shutterstock. So, fast food, ready availability, pre existing obesity or overweight, eating socially and not due to hunger, having a poor selection of food, concentrating more on meat, carbohydrate and calories, and drinking fizzy drinks or sugared drinks. People have hanging belly and continue to indulge in high energy drinks. So, this is how it is produced. So, I've already mentioned that leptin, which is a satiety hormone, affects many organs of the body, such as increased deposition of fat, leading to high cholesterol, and then eventually leading to hypertension. It replaces immune cells and so reduces body strength and produces vulnerability to infection. Its resistance leads to hunger. Leptin, when suppressed, can lead to menstrual disorders, bone pains. It can also lead to its effects on beta cells of the pancreas. So it therefore can affect release or suppression of insulin. So, what does one mean by physical inactivity? In the UK, 34% of men and 42% of women are not active as much as they should be. The Chief Medical Officer of England has suggested that over a week of 7 days, there should be at least 150 minutes of moderate intensity activity or 75 minutes of vigorous activity or a mixture of both. And ideally, this number can be met by 30 minutes of such exercises undertaken daily for 5 working days. Acceptance of physical activity in relation to sedentary behavior is strongly linked to obesity. Sometimes, if a person is on shift duties and continues with extended periods of work, he gets exhausted and therefore he will either get anxious, depressed, or not have enough opportunity to undertake physical activities. He'd become a desk jockey. So, social and psychological factors we have discussed already. So, this is an NHS chart produced by the Chief Medical Officer of England, and it explains what I've just mentioned. So, which medical conditions are strongly linked or can lead to obesity? Cushing's syndrome. Excesses of cortisone will lead to fluid retention, some muscle buildup, and dispersion of fat. This is described in terms of its features as a lemon on sticks. So, weight gain is mainly in the center of the body. PCOS is also a well known condition with its predilection to insulin resistance, relative hyperglycemia, if worse, and therefore also associated with fluid retention. Metabolic syndrome is characterized by what I have created a mnemonic as HADO for: hypertension, insulin resistance, dyslipidemia, and obesity. So, those conditions which cause fluid retention, such as congestive cardiac failure and hypoprolactinemia, can also lead on to producing obesity. Hypothyroidism is also something which leads to obesity if the thyroid levels are allowed to remain erratic. Some patients blame underactive thyroid for their obesity without realizing that when diagnosed and detected, the hormone levels are kept in the normal range. So, therefore, their metabolic problems, such as obesity, are no longer related to thyroid insufficiency. There are some genetic syndromes which are associated with hypogonadism, which can lead on to obesity. Prader-Willi syndrome, where a person is constantly hungry and is therefore eating most of the time, and there is very strong leptin resistance to this. Lawrence Moon Beetle syndrome, also a genetic condition leading to obesity, but in this, there would be a considerable amount of static disorders as well as neurological disorders of spastic paresis and this. And these conditions of disability will lead on to reduced activity, hypothalamic damage due to tumor, trauma, or surgery can cause obesity in the long run. Growth hormone deficiency is also one of these conditions which lead to obesity. Malnutrition or hypoproteinemia in Kwashiorkor syndrome is a disease of third world countries where nutrition is deprived or is deficient, and it leads on to obesity. So, what are the medications linked to development of overweight or obesity? Corticosteroids, and we've already discussed this. Antidepressants of tricyclic antidepressant nature, such as amitriptyline, nortriptyline, and monoamine oxidase inhibitors. In a long term basis, they produce inactivity, lack of desire for exercises, and some degree of fluid retention. But it's mainly the physical inactivity which contributes to overweight rather than fluid retention. Lithium, clozapine, quetiapine, and haloperidol are linked to obesity. The pathological way in which such antipsychotics produce obesity is not yet known. Those medications which lower glucose, such as insulin, sulfonylurea, thiazolidinediones, they are all linked to obesity. Some old-fashioned beta blockers, which are non-cardioselective, such as atenolol or metoprolol, these are related to obesity, but the link is vague. Anticonvulsants and receptor blockers, such as gabapentin, pregabalin, valproate, and carbamazepine, are linked to obesity, but the exact method is still unknown, and it is likely that the physical inactivity produced by these anticonvulsant agents may be the prime reason. There are other risk factors as well, which don't fit into the category of illnesses or medication contributing to overweight and obesity. Health Service of England has already mentioned the two peak age bands for producing obesity in adults: 55 to 64 and 65 to 74. During the phase of menopause and menopause itself, there is a degree of psychological depression, fluid retention, and many other psychological changes which produce obesity. A history of prior pregnancy, cultural changes. In certain cultures, multiple pregnancies are preferred. Environmental and socio-economic factors we have discussed already, leading to obesity. Deprivation of sleep, lack of education, poverty, and low socio-economic status also contribute as strong risk factors leading to obesity. So, why are we concerned about obesity and what can it cause or aggravate? So, with obesity, many of the medical conditions that we are fully aware of in relation to a rising age occur at a much younger age band. So, younger people, if they are obese, have a greater chance of developing type 2 diabetes, hypertension, ischemic heart disease, and cerebrovascular accident. Some cancers link up with obesity, and it's possible that the obesity in itself is raising the risks of such cancers. They relate to breasts, colon, and endometrial. There can be pathological visceral problems with obesity, such as non-alcoholic fatty liver disease, gallbladder disorder and gallstones, and gastroesophageal reflux disorder. Obesity can also increase the incidence at a younger age of acne, eczema, obstructive sleep apnea, weight-bearing osteoarthritis, and a degree of mental health, mostly depression, but also anxiety. Obesity can reduce life expectancy. So, at the body mass index between 30 to 35, which is stage 1 of obesity, 2 to 4 years of life are reduced. And with morbid obesity, with BMI of 40 to 50, around 8 to 10 years of life is lost. With obesity, there is a huge economic NHS burden, and this amounts to 6 billion every year at the current stage. And the projection suggests that in the next 15 years, it's going to rise to 9.7 billions per year. In 2023, 1.2 million hospital admissions had documented obesity as one of the important factors. With obesity, the social problems encountered in young age are mainly lack of employment and promotion, non-availability of trainings for future promotions or promotions themselves. So, what is the prognosis of obesity? It is clearly well known that most of the complications of obesity can be reduced by appropriate weight loss. But it is a chronic disease, and so it can return. And therefore, the weight management should be lifelong. Bariatric surgery is the most effective treatment for obesity in terms of long-term weight loss and improvement in comorbidities and quality of life, and also decreasing overall mortality rate. But prior to bariatric surgery or after bariatric surgery, lifestyle intervention must continue. Simple lifestyle intervention can lead to 5 to 10% of weight loss, but in this case, the relapse rate is 50%. Obesity medication plus lifestyle intervention is better, but relapse is also common. So when the lifestyle intervention is abandoned and drugs are stopped, obesity returns. So if 10% weight loss can be achieved in patients who are currently living in happily with obesity, then these are the factors of benefits. Mortality is reduced by 15 to 20%, significant improvement with blood pressure in hypertension, 30 to 50% reduction in fasting glucose, and 15% reduction in HbA1c. Lipids can be reduced as 10% of total cholesterol, 15% of LDL, and other forms of protein such as high-density lipoprotein, triglycerides. They can all be improved. 10% loss of weight can lead to improved lung function, insulin sensitivity, improved fertility, reduces back pains, joint pains, and sleep apnea. So let's talk about medication for obesity. It must be clearly emphasized to the patient concerned that the treatment includes pre-medication dieting, exercising, behavior change, stress control. And if a person can sustain these, and if the weight then becomes static, having been lost to some extent, then medication can be used unless contraindicated due to allergy or other medical reasons. In the USA, the drugs which have been approved include orlistat, phentermine topiramate, naltrexone, bupropion, liraglutide, semaglutide, tirzepatide, and these can be used for long-term basis. So individual selection of patients is made in the USA, and it's the obesity clinic which determines which medication should be used in relation to a given patient. NICE in the UK recommends orlistat, liraglutide, semaglutide, and tirzepatide. Ozempic, which is a form of semaglutide with a reduced dosage, is now approved by NICE for weight loss. Previously, it was approved for diabetes only, but it's now been approved for weight loss since September of 2024. So let us look generally at these medication. Orlistat. This is generally prescribed for BMI 30 or more or 28 plus in ethnicity, but with associated risk factors. It inhibits gastric and pancreatic lipase, and lipase is needed for fat processing. It should be stopped after 12 weeks if body weight loss is not at least 5% of the initial weight. The adult dose is 120 milligram capsule taken 3 times a day, preferably before meals, but it can be used after meals as well. Orlistat is licensed for 12 plus in children, and the dose for 12 to 17 years old is similar to adults. The main side effects would be bladder pains, general aches, rigor, cough, shortness of breath, diarrhea, and fever. Liraglutide, trade name Saxenda, is a GLP-1 receptor antagonist, and it's indicated for adults when their initial BMI is 35 or more, and these are non-diabetic hyperglycemic patients, and there is a higher risk of cardiovascular disease. So liraglutide is used for weight reduction whilst it remains an anti-diabetic drug, and its use reduces cardiovascular risks. It is usually prescribed by a secondary care or a specialist in weight management, and that such prescription is linked with obesity management service. Priming dose is a subcutaneous injection, 0.6 milligram per day subcutaneously for a week, and increased to 1.2 to 1.8 milligram for another week or two, and then 3 milligrams per day. Maintenance dose is 3 milligrams per day subcutaneously. Liraglutide has numerous effects. It affects the pancreas beta cells. It causes satiety, and therefore there would be reduced appetite and there is some neuroprotection. It delays the emptying time of the stomach. It improves insulin sensitivity. The side effects would be nausea, vomiting, constipation, diarrhea, and abdominal pains. It can increase heart rate and it can promote through its lipase activity incidence of pancreatitis. Semaglutide. This is also a GLP-1 receptor antagonist and is currently related and approved for weight management of 30 to 34 BMI. And if in an ethnicity issue, there is at least one weight-related complication present, it should be prescribed by an obesity management service. Now, an NHS prescriber is allowed to prescribe since September of 2024. The maximum adult dose is 2.4 milligrams subcutaneously once every week. If sufficient weight is lost and the clinician and the patient wish to continue without developing any opposing side effects, then the maintenance dose would be 1.7 milligrams per week subcutaneously once a week. So we've already discussed the side effects of semaglutide. These are mainly GI tract, producing belching, bloatedness, vomiting, and either constipation or diarrhea, abdominal pains. It produces lowered blood sugar in people with type 2 diabetes. Its side effect includes vasomotor issues such as not being able to deal with postural changes, runny nose, sore throat, or abnormal tears. I think we would be quick in describing various forms of bariatric surgery. Bariatric surgery is intended for current and future weight loss. It is different to surgery done for cosmetic region, such as tummy tuck or other adiposity-related problems. So the referral for bariatric surgery would be when the BMI is 40 or more, or between 35 to 40, with an improvable, significant medical condition. This is now allowed with such reservations to South Asians, Chinese, other Asians, Middle Eastern, Black African, or African Caribbean people, when their BMI can be accepted to be 2.5 kilogram per meter square less than the Caucasian patients. With the new onset diabetes and associated issues, bariatric surgery consultant can look at the patient through an NHS referral. So we'll quickly go over various forms of popular bariatric surgery models. There is gastric band, gastric balloon, gastric bypass, and sleeve gastrectomy. These are the popular methods of offering bariatric surgery. So the complications of bariatric surgery relate to those complications which are present with any major surgery and when anesthetic is given. They are 7% present or possible with laparoscopic bariatric surgery, but 14.5% through open surgery. Obviously, lap surgery is preferred. However, having mentioned of the complications, new researchers, one in particular, looked at 401 procedures with 0% mortality rate, 995 procedures showing 0.6% mortality rate and serious complications. And it is presumed that mortality rate and complications following bariatric surgery relate more to pre-existing risk factors such as obesity, class, previous history of pulmonary embolism, ischemic heart disease, obstructive sleep apnea, or haphazard control of diabetes. It is also well recognized in teaching institutes that a bariatric surgeon needs to undertake around 100 cases dealing with any complications successfully himself or herself. And that is the surgeon's learning curve. With this number, he is capable of dealing with usual complications in a team. The two residual complications after bariatric surgery would be in some patients dumping syndrome, and we'll discuss this, and nutritional deficiencies. And these relate to vitamin D, calcium, iron, thiamine, and vitamin B12. So this is gastric band or lap band. So taking hold of a part of the fundus of the stomach and just below the cardia, which is the esophagogastric junction, a silicone band is put in and tightened, and it can be further tightened or loosened through a device which is then put in the extraperitoneal and subcutaneous space, so it is easy to retrieve or control. This allows a much reduced quantity of food to pass in, and it will go slowly. And because the stomach will be filled less, there'll be no stretching. And of course, the stomach content, which is basically enzymes, acid, and some food, would continue to pass on into the normal tract of duodenum and small intestine. So if you look at this, the next method is an intragastric balloon. So the balloon is introduced via esophagogastroduodenoscopy and left in the proximal but inflated part of the stomach. And it is then ballooned up either through saline or through air so that it would allow a limited amount of food to pass, and the stomach will therefore not fill up, and through stretching effect it would produce a satisfaction of satiety, and therefore there will be much less hunger. And so with reduced food intake, a person is likely to lose a substantial amount of weight. Gastric bypasses. So that means part of the fundus of the stomach is cut and stapled, and the esophagogastric junction is anastomosed to a small part of the stomach, and into which is connected a loop of jejunum. So the food would then, as one swallows it, it will go into the cardia, it will go to cardia, it will come out mostly into the jejunal bypassed loop, and it will go down and join up much distally into the rest of the jejunum. So what happens to the rest of the stomach? So this is better explained in this next slide. So normally food goes down into intact stomach through the cardia into the stomach, and there is a set speed of clearance, stretching by food, and then pushing in through contraction into the pylorus and then to the duodenum. This is the normal route. So as you can see, the part of the fundus is cut and is stapled, So therefore, this is a blind loop. And then the part of the small fundus here and the cardia is linked to a jejunum loop, and this is connected up to the later distal part of the jejunum like this. So what happens is that the food doesn't go into the stomach, but the enzymes, pepsinogen and others, and hydrochloric acid and other vitamins are usually produced, and they follow the usual anatomical path. And because the duodenum is intact, it receives from the pancreas the pancreatic juice through duct of Santorini, and through the sphincter of Oddi it receives the bile from the bile duct. So the enzymes, acid, and digestive materials are all present. And because the food, when swallowed in small portions, because this gets filled up and it stretches, producing satiety, that means lack of hunger. So the food goes down slowly, but when it does, it suddenly directly is received in the jejunum. It is only much later that the stomach acid and the pancreatic and biliary contents are added from the duodenum into that part, that a mixture takes place. This is something which often produces rushing of food directly to jejunum in an unprocessed form, and it produces dumping syndrome. So that can be controlled. Then there is sleeve gastrectomy. So the stomach is incised and a large part of it is cut out. Eventually, hemostasis is achieved by stapling the blood vessels, and this section of the stomach, which is almost nearly 80% of the stomach, is removed and thrown away. Whereas the esophagus and is attached to the cardia, and then this goes on through stapling in a sealed manner, it goes on to the pylorus. And because it goes on to the pylorus, it is capable of receiving some acid and some enzymes from this small part of the lesser curve of the stomach, and then it goes on further. So as you can see, if you allow a small part of fundus to remain intact and then cut out a sleeve of your stomach in this way, you can remove 60% of the stomach, which is excised and thrown away. The rest is stapled. So there is sufficient stomach content available, stomach lining, and the lesser curvature for the food, acid, and enzymes to mix together and then carry on through the pyloric intrum into the pylorus and through the duodenum. So these are various forms of bariatric surgery. I hope I've not confused you with the presentation, but the idea was to gather together, collate information from Europe, USA, other parts of the world where they have done abundant and important research, such as Canada and Australia, and then to put these together in a logical fashion so that one would understand how obesity is produced, what its problems are, how it can be prevented, how it can be treated essentially through lifestyle intervention of selective dieting and controlled physical energy expenditure by exercises, and often supplemented by obesity medication to suppress appetite, to allow slowing down of the stomach pumping, and therefore in making sure that the person remains satisfied with a smaller meal. And in addition, we've also brought into some discussion about the modern medication used for obesity management or overweight management, and some form of bariatric surgery and its principles. Thank you for attending. And I feel that the information in this presentation would generate further interest in people who listen to it to undertake their own research, to look at the patient population under their control and see what can be done to prevent and to control overweight at its beginning, and hopefully it will yield good results. I know you have already known the greater part of the presentation yourself through experience and learning, but I wish to collate the other information, the new guidelines, and to put them all together. Thank you for attending. Thank you. Bye-bye.